All right, let's dive straight into this explainer and really sharpen those rapid-fire diagnostic instincts for some incredibly high-stakes clinical scenarios. Welcome, everyone. Today, we're taking a hard, structured look at the tipping points and, frankly, the fatal flaws that can happen in genital urinary and pelvic emergencies. You know, in medicine, there are these critical moments where recognizing the true signal through a sea of noise literally means the difference between saving an organ and irreversible damage. So, let's get into it.
Before we jump into the actual protocols, I want you to ask yourself how you'd handle this catastrophic clinical error just waiting to happen. Picture this. A 16-year-old rolls into your emergency bay with acute, severe, right-sided scrotal pain and a visibly swollen hemiscrotum. The clock is ticking. Fast. Do you elevate the scrotum? Do you pump him full of antibiotics? Or do you send him straight to the OR? Making the wrong choice here, basically misinterpreting the structural clues, can lead straight to tissue death. No pressure, right?
Okay, here is our mental map for today's audit. We'll be hitting 4 main stops. 1. The acute scrotum dilemma. 2. Urethral trauma protocols. 3. Pelvic ischemia and occlusion. And 4. Managing urinary obstruction.
Starting off with Section 1, the acute scrotum dilemma. Now, this is a classic 50-50 dilemma, and honestly, it's where a lot of really good clinicians get trapped. You see a swollen hemiscrotum, you run a urinalysis, maybe you spot some trace leukocyte esterase or isolated pyuria, and your brain goes, it's an infection. Well, hold on, that is clinical noise. It's often just localized inflammatory translocation. The true signal you need to look for is the cremasteric reflex and the anatomical axis. See, acute epididymitis preserves that reflex, keeps a normal vertical axis, and might even give you a positive Prain sign, meaning the pain actually gets better when you elevate the scrotum. Testicular torsion, on the other hand, that shows an absolute, undeniable loss of the cremasteric reflex, plus a high-riding, horizontally oriented testis because the spermatic cord is all twisted up.
Just take a look at this transverse Doppler. It visually proves our tipping point perfectly. On the one side, the affected right testis, you can clearly see asymmetric swelling and a stark total absence of intratesticular arterial blood flow compared to the healthy side. That dark empty space? Yeah, that is the definitive signal of an ischemic event. There's literally no blood getting through.
So here's a massive execution gap you've got to avoid. Delaying immediate surgical detorsion just to get a confirmatory ultrasound when the clinical presentation is already textbook. You literally cannot afford to wait. Every single hour increases parenchymal necrosis. If you suspect torsion, your execution path shifts instantly to surgery within 6 hours, period. Now, if imaging or surgical delays are completely unavoidable, you have to step up and attempt manual detorsion immediately, rotating the testis outward, kind of like you're opening a book. But definitive treatment is always going to require a bilateral or chiopexy to anchor both testes. Moving right along to Section 2, urethral trauma protocols. When you're mapping out pelvic disruption, you really have to distinguish between high-energy pelvic ring fractures and isolated stratal impacts. Posterior injuries, those happen at the membranous urethra, usually from pelvic fractures. Anterior injuries involve the bulbous urethra, typically from stratal impacts. But listen, regardless of the exact mechanism, blindly inserting a Foley catheter into these trauma patients is an absolute never event. Seriously, doing that can easily convert a partial mucosal tear into a complete transection. You do not want that on your hands. Instead, you've got to perform a strict mechanical audit to map the urethral integrity first. Step 1, identify your red flags. Is there blood at the meatus? Do you feel a high-riding prostate? Is there a perineal hematoma? If the answer is yes to any of those, step 2 is non-negotiable. Stop. Withhold the catheter immediately. Step 3 is to execute a retrograde urethrogram to visualize the exact structural architecture of the disruption before you do anything else. All right, Section 3, pelvic ischemia and occlusion.
Let's talk about aortoiliac occlusive disease, better known as Leydig syndrome. You need to instantly recognize this classic triad of symptoms. When peripheral arterial disease hits the aortoiliac bifurcation, it essentially cuts off blood flow to the entire lower pelvic and leg regions. The presentation is incredibly specific. You're going to see claudication, so pain that gets worse with exercise and better with rest, specifically locating in the hip, thigh, and buttocks. Add erectile dysfunction to the mix, along with physically decreased or totally absent lower extremity arterial pulses, and boom, you have confidently identified Leydig syndrome.
Now let's look at the numbers. An ankle brachial index below this exact decimal, 0.90, confirms peripheral arterial disease, and a severe drop below 0.4 signals critical resting ischemia. The ABI is just a beautifully objective tool. Normally, Doppler readings at the ankle should be above 90% of the brachial readings, right? But once you dip below 0.9, you have officially diagnosed the occlusion. And if that number plummets below 0.4, that patient is experiencing rest pain. That means the tissue is literally starving for oxygen, even when they're sitting completely still, putting them at massive immediate risk for necrosis and gangrene. Finally, Section 4, Managing Urinary Obstruction. In this scenario, you must promptly decompress the bladder to prevent an insidious, silent cascade of irreversible renal and structural damage. Unlike our trauma scenario earlier, if a patient has an acute obstruction, let's say from a severely enlarged prostate, acute catheterization is exactly what you need to do. By draining that backed up urine, you immediately relieve the massive pressure inside. This stops the bladder wall from rupturing, it saves the urothelial cells from pressure-induced necrosis, and crucially, it halts the backward flow of pressure that leads to hydroureter and ultimately just destroys the kidneys. Just look at the horrific consequences of a missed obstruction here. On the left side, those dark, dilated areas are the renal pelvis and calyces, and they are stretched to their absolute limits. You can see how the renal cortex is severely thinned out, essentially dying and drowning in fluid. It's severe hydronephrosis. Now, compare that to the healthy, nice, thick cortex on the right. This visual right here is exactly why immediate decompression is completely non-negotiable. Because when seconds dictate the survival of organs, knowing exactly what not to do is your most powerful tool. But before we wrap up, I want to leave you with one final catastrophic execution gap to think about: the delayed diagnosis of testicular rupture. If a patient presents with a scrotal hematoma after blunt trauma, do you just hand them some ice packs, tell them to elevate it, and send them home? Absolutely not. You must obtain an immediate ultrasound. If that tunica albuginea is breached, you have exactly 72 hours to surgically debride and close it to preserve spermatogenesis. So in the absolute chaos of an emergency, will you recognize the true signal through the noise before a tipping point becomes a fatal flaw? Stay relentlessly focused, trust your audits, and I'll catch you in the next explainer.